So basically, I'm gonna have like 50 minutes, right?
Yeah, 45 to 50 minutes, definitely. And at the point, we'll be having questionnaire.
After that, okay?
Yeah. Okay, so we are live now. So first of all, I'd like to introduce myself. I'm Dr. Gagandeep Kaur, the team member of GOMA and also the Global Interdisciplinary Summit. And first of all, I would like to introduce GOMA, basically, the Global Outreach Medical and Health Association. That is a global organization that is representing the medical as well as the health profession. It promotes and provides accreditation, certification, education, training, and other resources for organization, professionals, and students. The Global Outreach Medical and Health Association has firmly established a leadership role in medical and health sector. So I would like to inform every participant who are actually listening to the session that the participation certificate will solely be presented to all those who are the GOMA members. And if you're not carrying any sort of GOMA membership, you can kindly register to it by going on www.gomha.org. And you can share the link. The link can be shared to you if you'll be providing us with the email ID and everything. And moreover, a form link, a registration link will be presented to the session, and every participant has to fill the form. Along with that, need to have a screenshot of the session as a proof. And after that, after the submission of the form, the certificate will be directly mailed up to everyone through their mail. So moving on to the speaker of today, Dr. Stankov. I would like to introduce our current speaker. He's basically among the best positioned professionals in the domain of dental medicine in Bulgaria. He's managing a team of 24 employees as the chief doctor at Dr. Stankov's Dental Clinic. Dr. Stankov's clinic work is focused on end-to-end ethical treatments in dental medicine, implantology, periodontoplastic microsurgery, microdontal regeneration, complex cases of prosthetics or natural teeth and implants. He is a renowned and influential international lecturer, a trendsetter in his area of expertise. He has executed a number of courses for postgraduate qualification in the fields of periodontology and prosthetics. He has also won a second prize in the world 1-year master program of GIDE, Global Institute of Dental Education at University of California, Los Angeles. So I would like to tell every participant to enjoy the session. So the stage is to you, sir. You can share the screen with us and we can go ahead with the session.
Okay, hello to everyone. It's a pleasure to be here. I'm gonna talk today about the multidisciplinary case in the aesthetic zone, which is one of my favorite topics. First of all, I want to thank to the Global Summit for the prize and for everything that they did for me. And let's go directly to the topic. What I'm gonna talk today, I'm gonna talk about multidisciplinary cases in the aesthetic zone, but I have very limited time, so I'll focus on a few things. I'm going to show you a few, two cases actually, and I'm going to focus how I manage the space in the aesthetic cases, how we are planning with the lab, because in a complex aesthetic situations, very often it's needed to be the planning to be done with the lab. How I communicate with the lab, and during the cases, I'm going to share with you some tips and tricks of the way how I'm treating the cases. So first, I need to mention my dental technician. His name is Stefan Petrov. He's from Sofia, Bulgaria, and he's doing all the beautiful teeth that I'm actually presenting. Let's start with the first case. It's a young lady which come to my office with she want to improve her smile. This is her profile, and you can immediately see the problem. So let's go to the intraoral pictures. Here you can see what is the situation. We have two persisting temporary teeth, that one of it which I need to extract, and the other one I will keep, but this we will discuss later. So this is the situation. If we look at this profile, we have a canine that is very, very large, and in the same time we have a deciduous tooth. It's a canine again. which is small, and we need to improve that. The canine need to look like a lateral in the end, and the temporary tooth need to look like a really nice, beautiful, permanent canine. This is the frontal view, and this is the x-rays. Actually, one of the temporary tooth is in a very good conditions, the right one, but the left one, which is on the right picture right now, has some resorption on the root. And in a case like this, I don't want to make compromises, and the tooth with the resorption, I'm going to extract, and the other tooth I'm going to keep. You can see here the CBCT on the left side, the tooth is with a very good root, and on the right side we have some resorption, which is in the cervical area. That's why I'm going to extract this tooth. What I'm going to do here, we have a small DSD, and you can see that I can use some orthodontics here to manage the space, to bring the central next to the other central, and in this way I will increase the space for the implant of the position of the lateral, where we have a temporary tooth which I need to extract. This is the tooth with the resorption. And on the other side, we have two problems. The gingival on the tooth in the position of the canine is not perfect, so I need to make a crown lengthening, and the canine I need to transform into lateral. So I need to pay special attention to how to manage the spaces in this situation. So in the end, I have teeth that are in harmony, not too big centrals, not too big canines, and the laterals small and gentle. So first, I'm gonna start with the crown lengthening procedure of this tooth, which is of the position of the canine. I need to change the zenith like 1 millimeter, 1.5 millimeters to bring it apically. So first I'm gonna make a sharp incision here with a blade. See, now the bone is very close. So what I'm gonna do, I'm gonna raise a little flap, very small flap, just to be able to make 3 millimeters of biological width and to smooth the bone. Actually, I don't need to raise the flap to make this 3 millimeters, but I need to raise the flap mostly to compensate the thickness of the bone, because I need to work on the external part of the bone to make it thinner. So what I'm gonna do first, this is after the incision, I put a retraction cord and I make just a very quick composite just to be able to keep the tissue in place. Then I'm going to proceed after the composite with the flap elevation, and I want to expose the bone. This is a full thickness flap. I'm gonna make a simplified papilla incision here. Same on the distal. Then I'm gonna expose the bone. And here from the composite, I can measure exactly 3 millimeters vertical. And most important, I can thin out the bone, especially in the interproximal area. See here, I'm giving the distance for the biological width. Now it's 3 millimeters. And now I need to thin out the bone here. I'm gonna clean the soft tissue a little bit. And of course, since I raised the flap, I'm gonna polish the restoration just to improve the healing. This restoration will be changed with the crown, but I want to improve the healing by polishing the restoration. For the closure of these two papilla, I'm going to use a very simple sling suture, nothing special actually. I just want to keep the papillas in place so they will heal in the best possible way. This is the situation after the surgery, and we continue with the implant placement. You can see the pin for the implant is already in a good position for a screw retained crown. This is the tooth with the resorption that I decide not to keep. And this is the place where I'm gonna put the implant. As you can see, I have just like enough soft tissue, and I'm gonna compensate here with another soft tissue graft. I don't think so, because the soft tissue margin is very coronal. And after the integration of the implant, I can push this tissue, and in the end, I will have enough tissue. So this is the rare situation when I'm just going to put the implant and I'm not going to use a connective tissue graft. This is the positioning of the implant. Actually, here I have some problems with the positioning of the implant, because when I was in the perfect position, I was very close to the tip of the root of the central incisor. This is the implant. It's a V3 implant. This is the way I prefer to put this implant, with the triangular part to the front, but it's another topic. And I just put some bios in the place of the in the gap in front of the implant. And for the temporary tooth, actually, I'm going to use the same tooth that it was before, shortened and attached to the wire, the orthodontic wire. Here is the problem. On the right picture, you can understand that the implant is in a good position, but the apex of the implant is very close to the apex of the tooth. But it's not a problem because we have ongoing orthodontic treatment, and I can very easy change the inclination of the central incisor. My wife was the orthodontist in this case, but since I put the implant, I continue doing the orthodontic myself, the orthodontic treatment myself. And you can see here, I bend the wire so I can move just the apex of the root. And you can see here the tip of the incisor wedge, how the incisor wedge is going to move when I move the tooth. When I move the root, actually the incisor wedge, the mesial part is coming down. As you can see here, we have a very nice movement, and this can be confirmed with the x-rays. This is the x-rays from the beginning and the x-ray in the end of this movement. And even better, I have a CBCT. You can appreciate how now I have the proper distance. So here I'm still not using the implant for the temporary tooth. I just use the splint, which is after the orthodontics, and here just I bond the pre-existing tooth in place. After some months, I'm going to cut this part of the canine that is in the way of the mock-up, and then I'm going to insert the mock-up. This is the mock-up. It's not perfect because it's just additional mock-up. And with the preparation, I want to bring the teeth down. But nevertheless, I can at least appreciate the smile line comparing to the face and to the smile of the patient. I make the prep through the mock-up in order to be able to guide it, to have a guided preparation, because I want to stay in enamel as much as I can. And here we have a very extensive preparation on the canine, which is in the position of the lateral incisor. So I really need to be very delicate because I need to remove a lot of sound tooth tissue, but in the same time, I want to be in the enamel. For the deciduous tooth, I'm going to make a crown because it has a very big defect on the palate. That's why I'm going to make a full coverage crown. This is the rough preparation. And the most important key for me is in the cases when I need to manage the space is to be able to use a key like this, silicone key like this, in order to see where I need to put my transitional line angles. And the problem here is exactly at this part. If I want to make this canine, which is big, to look smaller, I need to bring the transitional line angles inwards. And this is the key the silicone key that I use for the preparation, the silicone guide that I use for the preparation for the crown, because I need to have an even space in order for my technician to be able to make a beautiful crown that fits to the laminate veneers. This is the impression with the implant. This is the implant insert. As you can see here, I just use a normal implant transfer. I'm not using custom. My technician is going to finish the soft tissue margin, is going to make it perfect on the model. And then when I insert the crown, I'm going to push a little bit, but it's not a problem. Actually, it's better. This is the second card. And after the impression, we continue, the technician produced the laminates. And this is the time of the bonding of the laminates. And here, this is the most honest picture. You can see how much enamel I preserve during the preparation and how much tooth structure I actually save. This is the canine on the left side and on the right side. On the right side, the canine needs to be lateral, it needs to be transformed into lateral. And the interesting thing on this picture is that with the guided preparation, actually, I was able to save all the enamel of the tooth, not all the enamel, but all the preparation is in enamel. I remove a lot of tooth structure, but in the end, I finish with the preparation that is all in enamel. So this is the picture right after the cementation of the restorations, after I remove the rubber dam. In here, you can see the tissue is traumatized a little bit, but it's not a problem this will heal very, very soon. Here you can see where was the clamps of the rubber dam. The clamps of the rubber dam on the central, on the canine, and here is the place where I push the soft tissue with the final crown. So I give my final view, the final shape of the soft tissue. I give with the final crown. So what were the key elements of this case? First, we need to make a very simple and very nice DSD in order to appreciate for the team and even for the patient what we're going to do. Why we need to move the teeth to put the implant and to make the proportions acceptable. Second thing that is very important in a case like this is the way that I prepare the canine to be able to transform it to a lateral incisor. And overall, we want to achieve a harmony of the gingival outline, which is even more, you appreciate it even more on the face pictures of the patient, and the relationship of the proportions between every single tooth and the teeth next to each other. If we have one very big tooth and a small tooth next to it, the contrast is very big, and this is not so pleasant for the eye. This is the situation after a few weeks. Already the tissue is mature and you can appreciate the aesthetics. Again, the key here was transforming the lateral, the central, the canine into lateral incisor. And this was done with this preparation and this silicone key that come from the buccal side. And there we can see how much we can reduce the line angles. This is the crown. The soft tissue and everything looks okay. This is the palatal view. We still have the retainer here because we finish with the orthodontics. After orthodontic treatment, it's good to have a retainer, especially on the central incisor, because there we have a very big movement of the root. And the palatal side of the implant, I always prefer to work with the screw retained crowns. There are some exceptions, of course, but I prefer to work with the screw retained crowns. Here, if we talk about the occlusion, it's very important that the left canine, which is a deciduous tooth, is in group function with the premolars, and there's no excessive force working over there. Because the root of this tooth is not perfect, there is really need to protect this tooth. So in the situations like this, when I have a weak canine, implant on canine, I prefer, if it's possible, to go with the group function of this side, which means that in the lateral extrusion, I really want to have the premolars taking part. This is the face of the patient after the treatment. You can see the way that the harmony is restored and the way that she looks now. And most important, you can appreciate the difference in this profile. The intraoral picture, the left side, the right side, again the left side, the case before, the case after. She looks different. When we put everything in a proportion, the teeth and the face, everything looks different. The most important picture for me is this profile, because here we have the biggest problems. We have a small tooth that was in a very low position. We have in the position of lateral, we had a very big tooth, and this was really disturbing for the eye. And you can appreciate after the treatment, the harmony is there. The central is dominant, the lateral is small, is gentle, then the canine is more dominant, especially in profile view, and there is a smooth transition between the canine and the premolars. Because sometimes when we aim to restore the dominance of the canine, we make it too big, and then the premolars looks too small. In my opinion, one of the hardest tooth to do is the upper canine, because it plays very important role, especially when you look from the profile. So we're going to continue with the next patient. Again, we're going to talk about space management, how we manage the spaces. This patient came for me for the same reason. She wanted to improve her smile. She had a trauma when she was a child. After that, they tried to place some composites, then they replace the composites. She had a lot of problems, and in the end she's in this situation. The patient didn't want to go to proceed with the orthodontic treatment. She said, please don't make orthodontic treatment on me, because she's working in a very special area, and she's smiling all the time. She's making a lot of pictures, and she don't want to wear braces even for a short period. This is the smile. This smile is in a horizontal line. The teeth are inclined. This is very important here. This is, again, the intraoral picture is parallel to the horizon. Just the teeth are like this. And on the X-ray, you can see some composite, even in the soft tissue, which we need to clean. And of course, we're going to replace the old composites, but this is not a topic for today, just simple replacement of the composite. And then we're going to proceed with the veneers. Let me share with you the video of the patient so you can appreciate how is she looking before we start the treatment. Actually, for me, it's very hard to make her smile because she's always trying to hide the teeth under the lip. Now she don't know that we are making video, and you can see how much of the gum we can see when she didn't know that we are making a video. A close-up of the face, again. You can see the papilla between the central and the lateral is very big. And the most important thing here is that we're seeing the gums. That means that we need to take special attention to the gingival outline if we want to finish with a nice result. Again, we're using a DSD to be able to orient the intraoral picture to the horizon. And actually, this is the orientation. The major problem here, one of the problems here, is the inclination of the midline. This is very noticeable, and we always try to make the midline to be parallel to the horizontal line. I think this is very important. We need to make it vertical. If we want to make it vertical and to keep the proportion of the central teeth the same, the form of the central teeth the same, we need to make some crown lengthening here. We need to push this like 3 millimeters. We need to cut it like 3 millimeters. The other central maybe just like 1 millimeter. Then we need to make a new zenith of these restorations, these teeth. After that, we're going to manage the space. And one of the biggest problems that me and my technician we found in this case is that the distance between the two canine teeth is very big. And actually, it's very difficult to make it in the end to finish with the teeth that look gentle, that look small. Because if we need to manage this space, the teeth will look very big if we keep this space the way it is. So what we're going to do, we're going to prep a little bit more to be able to physically reduce the teeth. And then we're going to use some tricks in the ceramics and the forms to make it optically look smaller. So in the end, we're going to make them physically smaller and optically smaller. We're going to create an illusion. This will be the end result on overall. So the technician needs to put the model parallel to the horizontal line and the teeth in the correct position. Then he's going to work. This is his drawing. He draws first on the model to be able to appreciate how much he needs to move the zenith, how much he needs to shorten the teeth, where he needs to put the midline. Then he's working on the model, like he's subtracting from the model, because we have parts of the tooth that we need to take out in order to create the midline in the right position and to create a smaller and gentle teeth. This is after the correction of the model. And after that, he's going to start to apply wax. And this wax up, I'm going to use for the preparation, to guide me for the preparation, and to make the temporary teeth. Because the last corrections here, we're going to make on the temporary teeth before we finish with the ceramic. But you're going to see this immediately in a moment. This is the texture and the form of the teeth. You can see the line angles are far apart from each other. And this actually allow for the light to go inside between the teeth, and the teeth look smaller because the reflective surface on the face of the tooth is smaller because the line angles are close to each other. So after we make the design on the digital smile design, we make the we worked on the model. My technician worked on the model. I have the exact measurements, how much I need to improve the zenith of each tooth. Actually, here, to be perfect, I need to make this zenith like 1 millimeter up, especially here in this area. I need to work on this zenith maybe like 2.5, 3 millimeters, this zenith and the zenith on the canine. For this, I'm going to use an electrosurgical unit. You can do this with a blade, you can do it with electrosurgery, or you can do it with a laser, but most of the time I prefer to work with electrosurgery because the tip is extremely fine and making extremely precise cuts. That's why I really love this unit. So this is after just the gum surgery. Here I only cut out the excess of the gum, and then I'm going to proceed with the osseous part of the crown lengthening procedure. What is nice here is that the bone is very close to the cemento enamel junction of the tooth, but in the same time the bone is thin. And when the bone is thin, I can just cut it away. If the bone is thick, if I just cut 3 millimeters, then again I have a very thick bone here, and it's very hard to be able to smooth the bone. That's why in the cases that I have a thick bone, I need to raise a flap. But in the case which is like this, I prefer not to raise a flap, not to cut the papillas, just a small tunneling flap to be able to access the bone, and then I just reduce. So there is a different approach when I have a thick bone or thin bone. You can see the bone is 0.5 millimeter from the gingival margin right now. First, I'm going to make a full thickness flap. This is important, full thickness flap, just to be able to access the bone. And after, first, of course, I improve the composite a little bit because I have a over contour here, and there is some staining and maybe calculus underneath. The patient underwent cleaning, but of course, in this situation with the composite, you cannot clean perfectly. But after I cut the excess tissue, I have access. So the bone is immediately here. This bone I need to remove. What I'm going to do first, I'm going to get access here for my instruments. To get access, I'm going to make a full thickness flap, full thickness tunnel of 3 to 4 teeth, just to be able to insert my instruments to work on the bone. Again, full thickness flap. This is very important. Sometimes you need to make a partial thickness here in the papillar area with the blade, just to be able to have an access. But very often you just need to make a full thickness tunnel, then you have an access for the instruments. This is the tunneling knife. It's a black one, which is visible through the soft tissue. It's very easy to control. I really like those instruments because it's very easy, fast, and safe to work with them. And this is the amount of bone that I need to remove. I'm using the protection. Here is the tunneling instrument, but when I start to work with the burr, I'm going to use Zachary retractor. It's a Gingival retractor because these instruments are very expensive and I want to keep them safe from the burr. So this is the Zachary retractor. You can see how I push the soft tissue and I work on the bone. But again, this is possible because the bone is thick, is close, is very close to the margin, but it's thin. If the bone was thick, I need to open a flap to cut the papillas or use other approach. I need to create a distance, usually it is 3 millimeters for the bone, for the biologic width. I'm not curating straight from the bone. I leave 1 millimeter and I'm curating the root above this 1 millimeter. And for the canine, because I don't have enough access, I'm going to use the curette. The tip of the curette is exactly 3 millimeters, and I'm going to use to remove part of the bone again. Here I have a small damage of the flap, but I'm going to fix it with a thin suture. This is a very gentle and small procedure, but in the same time, I need to be very delicate with the soft tissue. I need to be very precise. Now I have this 3 millimeters. I have this 3 millimeters. Actually, many colleagues says, and it's true, that you don't need to suture in the cases like this, but honestly, I always prefer to give some stability to the flap and to the blood clot. That's why I'm going to use a thin 7-0 suture. It's non-resorbable, just to make a tight adaptation of the papilla. I want to keep the flap that I raise, I want to keep it in place. In this way, there is no blood between the flap and the bone. That's why I need to push the flap to the bone. In here, of course, I need to suture this. It's better if I suture it. It's more stable. This is immediately after the surgery. And the funny thing is that the patient, she told me that she is already looking better because the gum line, the gingival outline is better and her smile is looking better. But of course, we're going to proceed with the treatment. This is on the suture removal. Usually for me, this is 7 to 14 days after the surgery. In this case, it's 14 days. This is the smile of the patient. You can immediately appreciate the way that the smile improves just by improving the gingival outline. Here we have the mock-up, and we're going to use again the mock-up to guide my preparation. How much space I need? I need 0.4, 0.5 on the buccal. But the most important thing when we need to manage the spaces between the teeth, when we need to make the teeth look smaller, is the interdental area. And I think I have in the video especially emphasized on this part. If you talk with the technicians, they will tell you that the most often place that they are lacking space is in the interproximal area when we talk about veneers, of course. This is the rough preparation. I do the rough preparation with the green burr, and then I proceed with the red burr to be able to make the smooth preparations. Here there is the pencil from the depth markers. I found this very useful. The first chord, I need to put the margin a little bit subgingival in order to control the zenith of the restorations. If the zenith is perfect, you can stay above the sulcus, but in this case, I need to control the zenith with final restorations. That's why I'm going intrasulculary, and this is very important, especially for the proximal areas. This is a 1 millimeter burr, and I'm creating just a small chamfer to give an indication for my technician where to stop with the veneer. And here, usually when we make veneers, we don't separate the teeth in this way, but here I need to make the central smaller and the lateral bigger. That's why I need to move a little bit. I need to create space between the teeth in order to have a ceramic there. That's why I'm separating the teeth. But I'm still in enamel. I don't need to cover this part with the ceramic. To finish the margin, very often I use the burr on a low speed without water. And this is one of the most important parts. I did the preparation across through the guide, so I have enough space for the veneers. But if I want a gentle form of the lateral, I want the lateral distal part to be curved. And very often, if I just let the preparation the way it is right now, the central incisor, the distal part need to go in this direction. And this make the the lateral look, the incisor wedge look bigger in this part and more triangular. So here, according to the silicone index that is from the wax up, I'm going to make it to curve this part to give the chance for so my technician can make a smaller round lateral incisors. Finishing the margin. We're going to use a feldspathic veneers here, so I need a margin like 0.1, 0.3, something like this. And this is the second chord, just before the impression. It's very important when you look to see the chord like this, the second chord you need to see. And in this place, you cannot see the chord. So very often, I just take the probe and take the chord a little bit out. Because if the chord is too deep, the sulcus is collapsing above it, and the impression material cannot go inside. So here I will change the chord, I will improve the position of the chord, and you can see the way the impression looks. So the wax up is not the final thing to discuss. The final changes we're going to make on the temporary teeth, on the teeth that we're gonna bond in the mouth of the patient for the time that we're going to make, my technician is going to make the veneers. And here you can appreciate the lack of support of the mesial part of the central incisors. So my technician need to put more ceramic there, make just a small over contour in order to keep the tissue in place. We need to thin out the centrals again. On the lateral, we want to improve the parabola, and we can do it because my margin is in the sulcus. So Stefan Petrov can push with the ceramic from there, and he can improve the parabola of the lateral incisor. But again, I need to give him this information with the pictures of the temporary teeth. So I make the preparation, I make the temporary teeth, and a few days later, ask the patient to come back to be able to see what I don't like, especially with the teeth proportions, with the spaces, and the area of the gingival outline. Here I make a little mistake. You can see on the left central, I forgot to take out one of the retraction cords, just a part of it, and I have an inflammation. But as I'm working with rubber dam, it's not a problem during the cementation. I think this can happen to any one of us. This is the model. This is a composite dies which help Stefan to create the best possible final cover. Because when we work with thin veneers, and for a case like this, it's very important to have a thin veneer. Because if you make a thick veneers, the teeth will stick out and they will be bigger. So we need to make thin veneers. When we use thin veneers, the natural cover of the tooth is very important because the veneer is thin. So I took from the prep teeth, I took the cover, and he make with the composite exactly the same cover on the model. And he can try on the model with the glycerin paste. This is a transparent paste, and he can appreciate the final cover actually, because the final cover here is from the tooth itself, from the cement. We usually use clear cement, and from the laminate restoration. This is a nice laboratory picture. This is a trying, just half trying, just the right, central, and lateral, to be able to see the difference between the temporary teeth and the final teeth. Is there a lot of change, especially the length, the proportions, and everything? This is the trying. This is the central with the glycerin paste. The lateral incisor. This is how I remove the temporary veneers because they're bonded. How do I bond them? I use a spot edge, and I put a spot bond, usually with a G-bond, and then I apply the veneers, the temporary veneers. I need to destroy the temporary veneers. And after that, I need to clean the small cement that I use for the bonding. This is the drying of the 4 veneers. we always use some paste to be able to appreciate the cover. In this case, it's translucent glycerin paste. So the cover, the fit, everything is okay. The palatal view, the fit is okay. I need to clean. This is aqua care. In order to have a good bonding, you need to have a clean surfaces. And I'm not cleaning only the buccal surfaces. I'm always cleaning the palatal surface too, because sometimes there is a biofilm and it can go to the buccal when you bond. You can touch something. So it's better to, in my opinion, it's very important to clean the palatal surface before you bond. I clean with just the aqua care, just the cleaning, not the scent. Here we have some remnants of the cement that we use for the temporaries. They're visible, very easy to see. It's better to remove them. I didn't make IDS in this case, median dental sealing, because I don't have exposed dentin or very small exposed dentin. Drying of the veneers. The fit is very nice. I do the final trying of the veneers with the rubber dam so I can see the fit. Fit is good, so I can proceed. In here, I use 27 microns of sand to clean the enamel. Here I have some composite left. It's very easy to see with a microscope. And again, the sandblasting. It's aluminum trioxide, 27 microns. Etching. After I bond the centrals, I'm going to bond the laterals. This is the lateral tooth. The etching. Here, when I blow, you can appreciate how much enamel I save in this situation. You can see the central that was virgin is 100% enamel, and I have, it's not dentin exposure, but you can see the composite. This is a new composite here. So this is the only problem area that I have here. And additionally, I'm going to use some Monobond Plus sealant on this composite to be able to reactivate the surface there and to make the bond stronger. This is the two laterals. Again, they're in enamel, so I feel safe. This is very important when we choose the feldspathic ceramic, and I really believe that the feldspathic ceramic is the best ceramic for cases like this. Immediately after the bonding, this is how it looks. And now we need to give a few days for the soft tissue to heal, and then we can appreciate the final result. The patient left, right. Now you can see the balance of the teeth. The central is dominant, the canine again is dominant, but not too much, and the lateral is more gentle. How we achieve that? With the preparation, we leave enough space for the light to go inside in here. So actually the reflecting surface is here. It's here, it's a small reflecting surface. In this surface that is from the contact to almost the center of the tooth is not reflecting. And the tooth is not only physically smaller, but is visually smaller. It's an illusion of a smaller tooth. When we have bigger shadow between the teeth and smaller reflecting surfaces, we have the illusion of a smaller teeth. So the preparation was very important, especially in the interproximal areas. And this curvature here of the lateral is possible because after I finish with the preparation, I smooth this angle. And then my technician can make this part more round and to make it physically smaller. This is how it was the patient before. Again, take a notice how the teeth, especially the left central and lateral, are almost square. And here they look much, much different. And this is after the healing of the tissues. The tissues now look much better. The teeth are in proportion, and they look really gentle, and they're fitting to the face of the patient. How we achieve this? The most important thing was to restore the proportion of the tooth, because we can reduce the width of the tooth, but not too much. We reduce it physically, we reduce it optically, but in the end, we finish with some width of the tooth. And to restore the proportions, we use the crown lengthening procedure to make the teeth longer, and the relationship, the ratio between the length and the width of the tooth is much, much better. And with the crown lengthening, we restored the gingival outline. Now it's much better. This is after some months. And the most important thing, the most honest thing, is when we can share a video of the patient after the treatment. This is how she looks like. Hope you can see the video nice, because on my laptop is going not in the best way. But in the end, the most important thing here is that we were able to restore the harmony, the relationship between the harmony of the gingiva, the relationship between the width and the length of the teeth, and in the end we were able to make them physically and optically smaller. Close-up of the face. Again, I think this is very important. And before I finish my lecture, I want to emphasize again the key elements. How did I manage the space? In these two cases that I show you, we had a bigger teeth, like the big cannon in the first case and the big centrobilateral in the second case, that we need to make them small. How do we make them small? We make them physically small by prepping the interproximal areas. We're using the buccal guide for this. Then we are making them optically small by putting the line angles close to each other and allowing more light to go between the teeth and reducing the reflection area. And in the end, we finish with the teeth that look smaller. Again, we use the crown lengthening procedure to make the proportion of the teeth better and to improve the gingival outline. Starting with the laboratory, we always try, not always, when we have a simple case, of course we can go with directly with the waxer or digital or manual waxer, it doesn't matter. But many times we discuss, I make a DSD and I discuss with the patient and with the technician, with Stefan Petrov, what we can make to improve the smile and how we can achieve it. If we're going to include surgery, orthodontics, just prosthetics, or we're gonna cover some recessions or whatever. Communication with the lab. We communicate after we make the mock-up. We give pictures to the lab, because very often when we talk about complex cases, I'm not talking about easy 10 veneers cases that are straightforward. When we have a complex cases, very often after the mock-up, we need to change little things, some position of the teeth. And when I put the temporary teeth, again, we can change little details. And I share with you some fixing trips on crown lengthening and the preparation and the keys that I use, because I think that for these 45 minutes that I have, I cannot tell you everything I know. I cannot share all my cases and all the information I have, but I just can focus on very important steps and share with you some tips and trips how to do. And with this, I want to thank you for your attention, for being here, and wish you health. And now I think I can answer some of the questions. Maybe I need to stop share. Okay, we are back. So do we have questions?
Yeah, thank you so much, sir, for an amazing lecture, actually. We are having some queries from the participants. One has asked for, what is exactly the zenith depth from the implant? There's a question, the case which you've shown in the initiation. So what sort of, what's the exact depth that has been asked by a participant?
Exact depth of the implant. We measure the depth of the implant with the final gingival margin. So when I know where is the final gingival margin, from there I need to measure. For the different systems actually is different. When I use Zimmer implants, I use 3 millimeters from this margin, and in the case that you saw, it was MIS V3 implant, and for this implant I prefer to have more space, like 3.5 to 4 millimeters from the final gingival margin. So it depends on the implant, but with the implants that I use, I can tell you exactly. For Zimmer 3, I prefer 3, and for MIS V3, I prefer to have 3.5 to 4 millimeters from the gingival margin that I want to be final.
Okay, thank you. And one more question we have is from Dr. Amit, that either lithium disilicate can be used as veneer.
Sorry, did I use disilicate?
Lithium disilicate.
Did I use? Yes, I use lithium disilicate. I work with Lisi and with Emax, but they're it's not my favorite material for veneers. I prefer to have a feldspathic veneers, or if I work digital, I prefer to go with Empress, for instance, because they have a much better fluorescence. The fluorescence is much better of these materials. Of course, I have a lot of experience with Emax and with Lisi, and I still prefer it when I have not enough tooth structure and it's not the best situation. I cannot be like 100% in the mouth. Then I make a compromise and I go with the Lisi or Emax. But in these cases, I prefer to have a more space and to place my technician to place a layering ceramics, because the layering ceramics has a very nice fluorescence. I don't hear the question. I don't hear the question. You're mute.
I think the answer would be quite clear to the participant. One more question we have by Dr. Rajesh. How do you decide on the crown lengthening limit or maximum we can reduce the bone?
Well, usually I can reduce, I never had a problem with the reduction of the bone. What I mean is, when I have this situation with the outer of passive eruption, it's not that, the bone is too high. It's already too high. It's not in a normal position. And that's why it's very rare that I even think about it, because when I restore the proportions of the teeth, I'm exposing the natural crown most of the time, and I don't really go in a worse situation because the bone is too high, and I'm just making the better position of the bone. Of course, there's some limitations when you have short roots after orthodontics or something like this, but we already know that short roots are not a problem, because I'm a periodontist and we have orthodontists in the clinic. We have a lot of cases with resorptions of the roots after orthodontics. Everybody knows about that. After periodontal problems, we have a very short roots that are in the bone, and we need to manage this with a splints or with a occlusal adjustment or whatever, but it's manageable. So I'm not really afraid, and most of the time I need to crown lengthen like 1 or 2 millimeters, and the bone is already too high. So in my opinion, it's not a problem. I never had a problem like this, and believe me, I make a lot of surgeries like this. But the problem is that the bone is too high.
Okay. Thank you so much, sir. I think we don't have much more questions to be asked for. Okay. So it has been a wonderful lecture, and with wonderful cases you've shared with us, that got knowledgeable for all of us. So I think we can go to the end of the session with this.
Okay.
And I would request all the participants to kindly register for the session with the form which is present in the link, and can go for the membership of GOMA for the certifications, for the C certifications as well. So thank you so much, sir. At the end, if you would like to add some words.
No, I just want to wish you to stay healthy in this situation, because nowadays this is the most important thing. So stay safe.
Definitely, sir. And a lot of regards you've got, like there were quite a lot of comments giving regards to your lecture, actually.
Thank you.
Okay. Thank you, sir.
Bye-bye.
Thank you so much.
Bye-bye. Stay safe and enjoy life.
You too, sir. Thank you. So with this, we brings to the end of the session.